Thanks for being with us today. Special guest, Dr. Wynn Moore, orthopedic surgeon. Mike Beam, who's a director of extra services and all sorts of special services at the hospital. Welcome. We're so glad you're here this morning.
Thank you.
Dr. Moore, with so many of the retirees that we have here in the Mountain Home area, and we've just got an older population in general. As an orthopedic surgeon, I'm sure that you might have some conservative ways that arthritis could be handled. We were talking about that a little bit during the break. Could you share some of those with us?
Well, indeed, we have a retired population. That's the makeup of our community. And indeed, arthritis doesn't have to be treated with surgery. There's no question that there are plenty of methods that will alleviate pain. And our goal in treating arthritis is to have someone be able to function at the level they feel appropriate without pain. And if we can do that with medications, which is very common, all the primary care use medications, which is the anti-inflammatories, injections will work. If we can do these things and avoid surgery, then we've accomplished our goal, which is to have a patient be active, enjoy their life without having to go through surgery. And there's some depth involved in non-operative treatment. For example, arthritis is divided into really three groups. Generally, we look at degenerative, which is the run-of-the-mill that we all get with time.
Age appropriate.
You should like your tires. If you run them long enough, they're going to wear out. And then we have post-traumatic, which is not as common, but someone has an injury years before. And then we have the inflammatory arthropathies. And they're treated a little differently in that there are other medications that we use, particularly the immunosuppressants, which our rheumatology colleagues generally treat that. When we get into using methotrexate or Enbrel, or that's in their area. But mostly it's medications, injections. Occasionally bracing may help, although it's not as helpful as a lot of patients would like it to be. But it's there. It's available. So, and that's always the first step, is to treat someone non-operatively.
And then once it goes beyond that, though, and it actually comes into your realm of orthopedics, what would the next things be that you...
Well, once we've gone through the steps of treating them conservatively, we have to look at what we're trying to accomplish. What are the things in their life that they cannot do? What are they lacking? If someone tells me, well, I can't skydive, I'm going to say, well, I'm probably not going to put a total joint in you. We're talking about what I call activities of daily living, which is getting up, getting around, going to the grocery store, going to church, things that we all expect and take for granted. Then we're in a situation where, yes, I think, there's something we can do for you. And then we start looking into how we're going to do it, what we're going to do, what type of knee or hip we're going to use. And obviously go through our whole process of explaining to them how they would get through this operation and what they can expect. And particularly what complications may arise from the surgery.
So that as an informed patient, they can make the decision with you what's going to be best for their quality of life.
In fact, I tell all of my patients that it is not my decision to operate. My goal, my role in this is to give you the options and to understand what you're looking at, whether it be non-operative or operative, and you sit down with your family and make a decision. I can't tell you or direct you. I can give you the information and tell you what you can expect, and you make that decision. That's the way it should be.
Absolutely. That way they're really informed. They really understand what they're getting into, because there's going to be some challenges, probably before, during, and after.
And what the last thing on earth you want a patient to say is, if they have a complication, is, I wish I wouldn't have done this, which they will anyway. But you don't want to look back and say, we could have done this, this, and this, and might have made you better. But now we've done a surgery and we've got problems.
Sure. The last thing you'd want.
Want to make sure that we have exhausted all avenues of treatment, and now this is what we've come to.
Can you tell us something about some of now I know that you do the direct anterior approach.
Yes.
Can you explain that more in layman's terms so that our viewing audience today has a better understanding of what that particular procedure is?
That's a specific approach to a hip replacement. Hip replacements have been done for forever, I mean, essentially. And we've gone through a lot of different ways to implant, which is the process of opening up the joint and putting in the implants. And they're all good. All of the methods we use are good. Each one has its own inherent problems and potential problems with instability. But the anterior approach is a little different in that we come from the front. We do not divide any muscle. We don't detach any muscle. We run between two layers. It's great because we don't disrupt the posterior stabilizing structures. The capsule, the short rotators, which are muscle and tendons, and therefore we have reduced the potential for dislocation tremendously.
And is the recovery time faster?
Much
also?
faster.
Much faster.
Now it's tougher on the surgeon because it is hard. It's harder to do because we're operating through a fairly small window. It's not extensile. In other words, we can't just open this incision up as big. We're very limited. But because we don't disrupt any muscles, the recovery time it's almost scary.
Oh.
Because I look back at patients that were taking 6 weeks plus to really be recovered, and these patients are doing great at 2.
Wow, that's a huge
difference. The average
difference.
is 4. Well, in some cases, the posterior approach can take 3 or 4 months to be completely over as far as muscle strength. So it is a big difference. And as you move from posterior to anterior, I think the recovery time in any of those incremental steps is better. Some of my colleagues do it through a kind of an anterior lateral approach, which is more posterior than I do, but it's much better than a direct posterior. So when you get to the direct anterior, it's kind of the best of recovery. Now, I always tell patients that there's no difference. If you look at your outcome at 6 months to a year, unlikely you will notice a difference. But it's that immediate, I can stand up and go home at 3 days and feel great about it.
So from a mental standpoint alone, that's a huge positive.
It is.
Yeah.
I recently did one of my younger patients, 62, and he went home at post-op day 2 because he just felt like he didn't need to be there.
Yeah, that's got to be just very rewarding
for
him, for you. And
absolutely.
Now, does that require special equipment?
It does.
Okay.
The hospital. Baxter has purchased for us the special table called the HANA table, which we've now had for 3 years. And it does require some specialized instrumentation, which we have. But it's still the same surgical techniques per se, but you have to have the right equipment to get in there.
Right.
So, and we have it.
So you have that, so you can do that smaller incision, as I'm calling it.
We do.
So, and I think too, a question that I had was, now with a smaller incision, and you were talking about with the muscle mass and everything that's in there, can your patients then start physical therapy sooner? Or is that something that there has to be a healing process?
All of our patients, no matter what approach, we start therapy right away.
Right away.
Right away. It eliminates a great deal of the restrictions that we place on the patient during the post-op period. With the direct posterior approach, we're very, very careful about not having them flex the hip too high.
Okay.
And they can't bend over as much. With the anterior approach, because we don't disrupt the posterior structures, we don't have those restrictions. So they can progress their therapy faster.
Wow.
And they're not required to use pick-up sticks because they can bend over. So in that respect, it moves the therapy faster, which is what makes the recovery time faster.
Faster all the way around. Okay.
Absolutely.
I wanted to be real clear on that because I was a little confused, and I'm thinking if I'm, I could be confused on any given day. So
I understand that concept as well.
We need to take just a short break Don't go away. We'll be right back. We want to hear more from Dr. Moore and from Mike Beam and find out what's going on in the orthopedic world. We'll be right back.